In this lecture, we are going to be talking about the disorders of potassium metabolism. Under this short outline, we will begin with a brief introduction, and then we'll talk about metabolism of potassium in the body, and conclude the lecture by talking about hypokalemia and hyperkalemia. Potassium is one of the most important positive ions in the body. It can be present either within the cell or outside of the cell, but it is mostly found within the cell alongside other important positive ions like sodium, calcium, magnesium, and hydrogen ions. But amongst all of these, potassium is the most abundant intracellular cation. As much as about 98% of all body potassium are found within the cell. However, there are mechanisms in the body that regulate the constant movement of potassium from outside to inside of the cell and vice versa. So at every point in time, there is a regular movement of potassium from outside of the cell to intracellular compartments and vice versa, depending on the clinical condition of the patient. These mechanisms ensure that majority of the potassium are moved from the extracellular space into the intracellular space in order to ensure that only about 2% of body potassium is retained outside of the cell. So, it is the extracellular potassium which is routinely measured that conveys clinical significance. However, several pathological or physiological conditions can cause the movement of potassium into and out of the cell to either increase or reduce the amount of potassium in circulation. When such changes occur, leading to either a very low or a very high level of potassium in circulation, the resultant effect can interfere with the normal functioning of several organs of the body. In fact, it can lead to a sudden death. And there are several known disease conditions that are associated with either hyper or hypokalemia. So it is a good clinical practice to be able to identify such symptoms of disorders of potassium when patient presents in either emergency sections or in regular clinics. So here is the question: why is potassium more predominant within the cell than outside the cell? I want you all to drop your answers in the comment section before we proceed. I would love to read your comments. Here are some of the reasons. Several of the intracellular anions have a very high affinity for binding potassium. Intracellular anions like proteins, nucleotides, and phosphate tend to attract a lot of potassium from outside the cell to within the cell, especially phosphate that are continually being generated from all or most of the cellular activities like creatinine phosphate, ATP, and other products of DNA synthesis, and a lot of the glycolytic intermediates. All of them build up within the cell and tend to attract a lot of potassium from outside the cell into the cell for binding. The second reason is due to the effect of sodium potassium ATPase, which is present in almost all the cell membrane of all cells in the body. It actively pumps sodium out of the cell and pumps potassium into the cell in reverse direction. So in nearly all the cells of the body, sodium potassium ATPase, which is a transmembrane protein, tends to pump potassium into the cell and pump sodium outside of the cell in order to maintain electroneutrality and establish an electrochemical gradient for sodium and potassium across all cell membranes. So for these reasons and several other reasons that you might find, potassium tends to occur more predominantly within the cell than in the extracellular space. Now, talking about dietary sources, potassium can be found in virtually all available food materials. Whether carnivorous or vegetarian, it is unlikely to find anyone who will be deficient of potassium if they eat well. Meat, vegetables, fruits, nuts, grains, and all types of food can supply the adequate amount of potassium that everyone needs per day. Upon consumption of food and digestion in the gastrointestinal tract, potassium is released into the intestinal tract and reabsorbed into the small intestine. So intestinal fluids are very rich in potassium, although most of them are reabsorbed back into the body. This will explain why any loss of intestinal fluid like diarrhea, ileostomy drainage, or any type of intestinal fistula will cause a very low level of potassium in the body. On getting to the kidney, almost all the filtered potassium are passively reabsorbed back into the body through the proximal tubule and loop of Henle. However, in the distal tubule and collecting duct, some amount of potassium are secreted in exchange for sodium reabsorption. In contrast to what happens in the proximal tubule, the secretion in the distal tubule is usually in response to the aldosterone effect. So, the presence or absence of aldosterone will determine how much of potassium will be secreted in the distal tubule. Also, a higher circulating aldosterone concentration will also mean that a lot more potassium will be secreted. In essence, any physiological or pathological condition that affect aldosterone concentration will also affect the amount of potassium that will be secreted in the distal tubule. Secondly, because the potassium secretion at this level is in exchange for sodium reabsorption, the amount of potassium that will be secreted is dependent on the availability of sodium. So the higher the amount of sodium available, the higher the amount of potassium that will be secreted and vice versa. Furthermore, potassium is not the only cation that can be secreted for sodium reabsorption at this level. The reabsorption can also take place in exchange for an hydrogen ion. So the relative amounts of either potassium or hydrogen ion that is available will determine which of them will be exchanged for sodium reabsorption. And this relativity can vary depending on the pH status of the body, whether it is acidotic or alkalotic. Meaning that in an acidotic condition where the body has a lot of hydrogen ion in circulation, more of hydrogen ion will be excreted in exchange for sodium reabsorption. Whereas in an alkalotic condition where the body has a very low level of hydrogen ion in circulation, potassium ion will be excreted in exchange for sodium reabsorption. Although the body has several mechanisms in place for ensuring potassium homeostasis, there are several situations in which losses are inevitable, and these losses have been classified to either renal losses when they occur in the kidney or extrarenal losses when they occur essentially in the gastrointestinal tract. One of the major causes of renal losses are renal tubular acidosis type 1 and type 2. In type 2 RTA, when there is a defect in the proximal convoluted tubule of the kidney is unable to reabsorb all the filtered potassium, and as a result of that, all the filtered potassium are lost in the urine. Whereas in type 1 RTA, where there is a defect in the distal convoluted tubule of the kidney is unable to secrete hydrogen ion, which will mean that all the sodium reabsorption that will be done at that level will be done in exchange for a lot of potassium ions. So, in both type 1 and type 2 renal tubular acidosis, there is a substantial loss of potassium in the urine. The second major cause is the use of diuretics, which are used in the treatment of either edema or in patients who have hypertension. And that is why one of the major side effects of diuretics is hypokalemia. The reason is that both loop diuretics and thiazide diuretics inhibit sodium reabsorption at the ascending loop, meaning that only a minimal amount of sodium will be reabsorbed at that level. And the consequence is that a large volume of sodium will be delivered to the distal tubule, and definitely The larger the amount of sodium delivered to the distal tubule, the larger the amount of sodium that will be reabsorbed at that tubule, and then consequently, the larger the amount of potassium that will be secreted in exchange for sodium reabsorption. That is how diuretics cause hypokalemia. Lastly, on renal causes is steroid excess. Steroids generally behave like aldosterone when they are present in a very large amount. And in such situations, they are able to stimulate the reabsorption of sodium in exchange for potassium, thereby leading to hypokalemia. So patients who are on steroid excess are very much likely to have low level of potassium because of the effect or the mechanism of operation that behaves like aldosterone. So any type of steroid that is given in excess will eventually lead to hypokalemia in the affected patient. With regards to the extrarenal losses, I mentioned earlier that the gastrointestinal tract is really rich in potassium. So most GIT fluids are rich in potassium. So any condition that will lead to the loss of a GIT fluid can also lead to hypokalemia. For example, in patients who have diarrhea or any type of fistulae or suctioning gastrostomy tube, all of these situations have been found to be associated with hypokalemia because of the loss of gastrointestinal fluid. So, based on the discussions we have had so far, I want you all to attempt these questions. What factors affect renal excretion of potassium? Please drop your responses in the comment section. In this slide, I'm going to explain three major factors that affect renal excretion of potassium, and they include sodium delivery to the distal tubule, presence of aldosterone, and hydrogen ion availability. Remember that sodium is predominantly reabsorbed in the proximal tubule. In fact, more than 70% of all the filtered sodium are reabsorbed in the proximal convoluted tubule, leaving only a very little amount, remaining close to 30%, to be transferred to the distal convoluted tubule for reabsorption. Therefore, any situation that will cause a distortion in this arrangement will mean that a lower amount of sodium will be reabsorbed at the proximal tubule and a larger amount will be transferred to the distal convoluted tubule for reabsorption. And this will definitely increase sodium delivery to the distal tubule. Now, somebody may want to ask, how does this affect potassium? And the answer is very simple. You know that in the distal convoluted tubule, for sodium to be reabsorbed, you have to give up either a potassium or an hydrogen ion. This is unlike what happens in the proximal tubule. So, for every molecule of sodium reabsorbed in the distal tubule, there's a corresponding loss of either a potassium or an hydrogen ion. Invariably, the higher the sodium delivery to the distal tubule, the higher the likelihood of losing either potassium or an hydrogen ion. So, the question is, what are the factors that can affect sodium delivery to the distal convoluted tubule? And the first one I want to talk about is the reduction in the glomerular filtration rate. Any condition that will reduce glomerular filtration rate will reduce the amount of sodium that will be delivered to the distal tubule. For example, a patient that has a reduced blood flow from any cause, either from a shock, dehydration, heart failure, hypotension, glomerular disorders, and whatsoever, including any type of nephropathies, all of this will reduce the amount of glomerular filtration rate, meaning that the glomerulus is not getting a lot of fluid to be filtered. In that case, virtually all the filtered sodium will be reabsorbed in the proximal tubule, leaving almost little or nothing for the distal convoluted tubule to reabsorb. In this condition, potassium is retained in the body and there is no loss. A similar thing will happen in acute kidney injury, in which there is a reduction in the amount of fluid that gets to the kidney, especially in the prerenal AKI. Because of the reduction in the blood flow to the kidney and reduction in the amount of fluid that flows through the kidney and the reduction in the amount of glomerular filtration rate, especially in acute kidney injury, virtually all the filtered sodium are reabsorbed in the proximal tubule, leaving little or nothing for the distal convoluted tubule, thereby retaining the amount of potassium in the body. However, in patients who are on diuretics, where there is a reduction in the sodium reabsorption in the proximal tubule and there is a large delivery of sodium to the distal convoluted tubule, there is a higher volume of sodium to be reabsorbed in the distal convoluted tubule, meaning that a lot more of potassium or hydrogen will be exchanged for sodium to be reabsorbed. That can cause hypokalemia. The second reason is the presence of aldosterone in circulation. Aldosterone is originally involved in stimulating the reabsorption of sodium in the distal tubule, and this it usually does in exchange for either potassium or hydrogen ion. So the higher the level of aldosterone in circulation, the higher the level of sodium that will be reabsorbed, and the higher the level of potassium that will be secreted in exchange for the sodium reabsorption. So in patients who have primary aldosteronism, there will be associated increase in the reabsorption of sodium and associated increase in the secretion of potassium, leading to a situation of hypokalemia. So patients with primary hyperaldosteronism will usually have hypernatremia and an accompanying hypokalemia. But the same cannot be said for people who have secondary hyperaldosteronism, and I want to leave that for discussion in the comment section. What do you think will happen to potassium and sodium in patients with secondary hyperaldosteronism? I want you to drop your comment in the comment section for discussion. The third factor I want to talk about is hydrogen ion availability. Remember I said earlier that anytime there is sodium reabsorption, it is done in exchange for either a potassium or an hydrogen ion. Now, the availability of hydrogen ion in circulation will determine which of hydrogen or potassium will be donated in exchange for the sodium. In situation of acidosis, where there is a very large amount of hydrogen ion in circulation, the body will rather secrete or excrete hydrogen ion in exchange for the reabsorption of sodium, meaning that for every sodium ion reabsorbed, the body will secrete hydrogen ion in exchange, thereby retaining potassium in the body. If this goes on for a very long time, the accumulation of potassium in the body will lead to hyperkalemia, and that is in a situation of acidosis. The converse will occur in a situation of alkalosis, in which there is a low level of hydrogen ion in circulation. In that situation, for every amount of sodium ion reabsorbed, the body will rather release potassium in exchange for the sodium ion reabsorbed. So, the more sodium reabsorbed, the more potassium is lost into the urine. And if this continues for a very long time, there will be a situation of hypokalemia. And this is why most times in an alkalotic condition, patient usually has hypokalemia. So the availability of hydrogen anion will determine whether the patient will lose potassium or will gain or retain potassium. So these are some of the factors that will affect how much of potassium is excreted by the kidney. In the next few minutes, I'll be discussing the endocrine regulation of potassium balance, essentially describing the major hormones that are involving in the maintenance of potassium homeostasis. This slide is showing the three major hormones that are involved in potassium regulation. And the first one is aldosterone, which we had especially talked about. Aldosterone is produced by the adrenal cortex in condition of low circulating blood volume, either due to dehydration or hemorrhage. It can also be produced in situations where a patient has low blood pressure and in patients with hyperkalemia. And the major mechanism of action is to stimulate the increased reabsorption of sodium in the distal tubule and increased secretion of potassium, leading essentially to hypokalemia. So, the higher the level of circulating aldosterone, the lower the level of potassium in the blood. So, any condition that will increase the effective circulation of aldosterone in the blood will also lead to a reduction in the level of potassium in the blood. For example, in primary hyperaldosteronism, one of the major findings is hypokalemia and hypernatremia. The second hormone that is involved in regulation of potassium balance is insulin, and it does that by enhancing cellular uptake of potassium. Therefore, this is a very important consideration for patients who are diabetic and they are on insulin therapy, because the higher the amount of insulin given to a patient, the higher the likelihood of developing hypokalemia. In fact, this relationship has been deployed in the management of patients who has a very high level of potassium. Once insulin is given, it is able to drive the potassium intracellularly and thus reduce the amount of potassium in circulation. And this can also explain why patients with complicated diabetes who have either a relative or complete absence of insulin usually end up with hyperkalemia because of the absence of insulin to drive the potassium into the cell. The third group of hormones are the catecholamines, which are produced essentially from the adrenal medulla, and they have a similar effect on potassium as insulin. Catecholamines are able to stimulate beta-adrenergic receptors, which can activate sodium-potassium ATPase, which will drive potassium into the cell and sodium in opposite direction. In addition, catecholamines can also stimulate both the insulin and aldosterone, which will eventually lead to increased potassium uptake by the cell and renal excretion of potassium, eventually leading to hypokalemia. Lastly, catecholamines can cause a shift in potassium from extracellular into the intracellular space, also causing hypokalemia. So, the three major hormones tend to favor the reduction in the level of potassium in circulation, and these characteristics have been deployed in the management of patients with hyperkalemia, especially the use of insulin therapy. Now, having talked about the metabolism and the regulatory mechanism of potassium, it is pertinent to state that there are some clinical conditions that can cause either an elevation or a reduction in potassium levels in the body. The reference interval of potassium is usually quoted to be between 3.5 to 5 millimoles per liter. So, any value above 5 millimoles per liter is hyperkalemia, while values below 3.5 millimoles per liter are called hypokalemia. In this slide, I'm going to be talking about some of the causes of hypokalemia. To begin with, I want to state that hypokalemia can either be true or false. True in the sense that there is an actual loss of potassium in the body, and false in the sense that there are no true losses of potassium in the body. There may just be redistribution between the intracellular and extracellular pool of potassium. Starting with the false hypokalemia, which is also called potassium redistribution. Because there is no true loss of potassium, but a mere exchange or redistribution of potassium between the intracellular and extracellular space. The first item mentioned here is insulin responses, and I already explained that in previous slide. Because insulin has the capacity to increase potassium uptake in cells. Same thing for catecholamines and beta adrenergic receptors. In addition, pseudohypokalemia due to increased WBC, that's white blood cell, can occur because of increased demand for potassium by WBC for their cellular activities. Most of the intracellular activity which require energy are also potassium dependent. So the higher the number of WBC, the higher the number of demand for potassium, and this may cause a temporary shift in potassium into the cell. Remember that sodium potassium ATPase is present in all cell membrane of WBC, which could mean that the higher the number of WBC, the higher the performance of sodium potassium ATPase, and the higher the consumption of potassium in the process. The next item on this list is hypothermia. And hypothermia has been found to generally increase the uptake of potassium by cells, especially muscular cells. So when there is hypothermia, there is an increase in the uptake of potassium, which can cause a temporary reduction in the circulating level of potassium. The last one is hypokalemic periodic paralysis, which is a genetic condition that is involved in temporary reduction in the level of potassium in the body, and then is associated with temporary paralysis of the body. Now, for the true potassium loss, you want to establish whether it's a renal loss or an extrarenal loss. And to do that, you need to measure 24-hour urinary potassium. If the 24-hour urinary potassium is more than 25 millimole per day, then it will be confirmed that the patient has a renal loss of potassium. But if the 24-hour urinary potassium is less than 25 millimole per day, it's either that the patient is not taking enough potassium through the diet, or there is either a GI or skin loss through excessive sweating. The renal losses are associated with either metabolic acidosis, acute tubular necrosis, or metabolic alkalosis, and the different causes under each section have been listed as shown. Now, what are the clinical features of hypokalemia? So, because of its involvement in muscular coordination, most symptoms of hypokalemia are muscle related. Muscles are involved in cardiac contractility, muscles of respiration, muscles involved in bowel movements are all affected by hypokalemia. In the heart, it causes a reduced cardiac contractility and cardiac arrhythmias. In skeletal muscles generally, it causes muscle weakness. In the GIT, it can cause paralytic ileus and constipation. And then I left pancreas and kidney for you guys to tell me what are the symptoms of hypokalemia that can be found in the pancreas and in the kidney. Please drop your comments in the comment section. On the other hand, hyperkalemia results when plasma value of potassium gets above 5.0 millimoles per liter. And the causes of hyperkalemia are listed in the diagram below. It could be due to pseudohyperkalemia, which is a false elevated level of potassium. It could be due to potassium redistribution, in which there is actually no increase in potassium but a form of redistribution from the intracellular to the extracellular space. And it could be due to potassium retention in the body. Hyperkalemia can occur when there is a breakdown of red blood cell, breakdown of platelets, or breakdown of white blood cell. each of them releasing intracellular potassium into the ECF. Hemolysis is particularly a problem in vitro when sample collection have been standing for a very long time without being attended to, and red cells start breaking down and releasing their intracellular potassium into the blood sample. This can cause a falsely elevated potassium level in the sample. With regards to thrombocytosis, a high level of platelets in circulation can cause elevated potassium, especially after clotting, in which the platelets will have broken down and released their intracellular potassium into the sample. Leukocytosis, on the other hand, can also cause a falsely elevated potassium level. This can occur due to increased cell turnover or in tumor lysis syndrome, where the white blood cell breaks down and releases their intracellular potassium into the sample. It can also be time dependent due to the reversal of the activity of sodium-potassium ATPase, in which intracellular potassium begins to leak into the sample after the sample is being kept for a long time. With regards to potassium redistribution leading to hyperkalemia, some of the causes include metabolic acidosis, in which there is a reduction in cellular uptake of potassium, and there could also be a reversal of the activity of sodium-potassium ATPase. Other causes including dehydration, massive tissue hypoxia, insulin deficiency have been explained in previous slides. With regards to potassium retention, it could either be due to a decrease in potassium excretion or an increase in potassium load in the body. And all the different causes are listed below. Some of them have been explained in previous slides. So, every patient must be evaluated to ensure which type of hyperkalemia is present, whether it is due to potassium retention, potassium redistribution, or due to pseudo-hyperkalemia. Most of the symptoms of hyperkalemia are non-specific. It can range from mental impairment, respiratory depression, flaccid paralysis of extremities, tingling sensation, and generalized weakness of the body. However, a severe hyperkalemia can cause sudden death due to a cardiac arrest. So every patient with hyperkalemia due to their background clinical condition must be given urgent attention in order to forestall this sudden death. I think this will be the end of the lecture. I have a couple of questions here. Question 1 says, match the following findings to their appropriate diagnosis. So what you are expected to do is to pick each item listed 1 to 5 and find the corresponding item listed A to E that match the items 1 to 5. For example, which of the items A to E will be more relevant with hypernatremia? Which of them will be more relevant with hypoosmolarity? Which of them will tally with pseudo-hyperkalemia? And which of them will tally with hypokalemia? And lastly, which of them will tally with dilutional hyponatremia? Question 2 says, laboratory findings in Crohn's disease include A. Hyperkalemia, B. Metabolic alkalosis, C. Hypokaluria, D. Metabolic acidosis. Crohn's disease is primary hyperaldosteronism. So which of these options will be found in a patient with Crohn's disease? Please leave your answers in the comment section. Question 3 says, substantial loss of potassium can result from all except A. Jejunostomy drainage, B. Diarrhea, C. Vomiting, D. Fistula. So which of the following can be associated with substantial loss of potassium? Please pick the correct answer and let's discuss it in the comment section. Question 4 says, one of the following is correct about potassium homeostasis in the body. Option A, it is almost completely reabsorbed in the proximal tubule. That's potassium. Option B says that exchange of 2 molecules of sodium for 3 molecules of potassium through the sodium-potassium ATPase at cellular level. Option C says that blood pH has a minimal influence on potassium homeostasis. Option D says that active reabsorption from glomerular filtrates regarding potassium metabolism. So pick any of the correct answers and let's discuss them in the comment section. Question 5 says, the sources of error in potassium evaluation include all except option A, phlebotomy technique, option 2, sample bottle, option 3, sample handling, option D, phlebotomy site. Please pick the appropriate answers and drop them in the comment section. This is the end of the lecture. Thank you all for listening. I will expect you to post any question that you may have in the comment section, and I'll see you some other time. Thank you all very much for listening. I will see you another time.